So good morning, everyone. We're delighted to welcome Dr. Priscilla Hsue today. Dr. Hsue is the Maurice Elizer Distinguished Professor of Medicine at UCSF and also serves as Chief of Cardiology at San Francisco General Hospital, as well as Associate Program Director for the UCSF Fellowship. I would say internationally, she's regarded really as an authority in the field of HIV-related cardiovascular disease. She's really conducted and led the foundational studies that help us understand disease mechanisms through patient-oriented research and clinical trials. She served as PI in over 10 R01s. She has a K24 mentoring grant. I would say I first met Priscilla when I was a cardiology fellow at UCSF. One of the best decisions I made was to work in her lab. And I would say 15 years later, I still turn to her as a trusted advisor and mentor for all things related to cardiology, but also life in general. And I think I speak for many of us in saying that Dr. Hsue really serves as an incredible role model as a leader in medicine, as a physician scientist, a clinician, a mentor, and just a human being. So thank you so much, Priscilla. We're really looking forward to your visit today.
Thanks, Jen, for the introduction. That was too kind. I'm really honored to speak here today. Thank you so much for having me. Okay, these are my disclosures. So, why are we here today? So I became interested in HIV in college, and I said, I'm going to come to San Francisco and study HIV. And I did a year in Howard Hughes lab with Werner Green and decided to pivot to cardiology. And at that time, took care of many young individuals presenting with heart attacks. And so it kind of precipitated my initial start of my research career, which was more description, then investigation of mechanisms. It's kind of then changed a little bit into therapeutic trials in different diseases. And I'll talk a little bit about future studies. And I think for the trainees here, and I'm going to present this as a nice linear pathway. I have failed many, many times. And I think you just really got to, like this panda, enjoy the process and get back up there. What about HIV? So these are some of the latest statistics. 40 million people have died, 39 million individuals living with HIV. Of course, in the United States, over 1 million individuals living, 32,000 new diagnoses, and it disproportionately impacts African-American individuals and gay and bisexual men. It's interesting, in 2021, this marks the 40-year anniversary of living with HIV. And today is actually World AIDS Day. I know we didn't plan this, but good timing. So these are some just basics of HIV, when to start a medication as soon as possible. What do we start? It's actually integrase inhibitors. And we're supposed to reach this target of 90% diagnosed, treated, and suppressed. Where are we? So we're close, but there's still lots of work to be done. The first case of cardiovascular disease in HIV was described in 1990. And so fast forward 28 years later, this meta-analysis shows that individuals with HIV are twice as likely to develop cardiovascular disease. The global burden has actually tripled in the past 2 decades. And so these are some of my take-home points for today. The population is aging. Cardiovascular disease continues to increase in prevalence. Chronic inflammation, immune activation in the setting of treated HIV strongly associated with cardiovascular disease. I think as a cardiologist in general, it's a fantastic model for chronic inflammation, help us understand more about cardiovascular disease in general. And for my infectious disease colleagues, understanding these inflammatory pathways in HIV has an impact on HIV cure. We've learned about this as a model to look at the impact of new viruses like COVID-19. I'll talk a little bit about biologic and gene studies in HIV. So let's first turn to some of the initial work, which was description of the clinical problem. So when I first started as a fellow at UCSF, my work was establishing the infrastructure to do clinical research there. And this involved like setting up mentors, collaborators across the disciplines, doing some training in atherosclerotic imaging. And I established this HIV cohort and characterized the risk. And so it takes a lot of time to develop clinical events. So the first studies in HIV were looking at subclinical atherosclerosis, so by my group and others, showing that it was indeed higher in the setting of HIV infection. So with time, then came the studies showing clinical events. This is done by Matt Freiberg, showing that HIV is associated with strong risk of acute myocardial infarction. As you can see here, it's higher even in younger individuals. That risk associated with HIV is similar to that of age, diabetes, and other very strong traditional risk factors. And so I think the earlier work that I've done is really bring attention to this critical issue, with regards to atherosclerosis, diastolic dysfunction, arrhythmias, pulmonary hypertension, stroke, and others. So I think one of the great things about being a mentor was that the individuals that I've mentored have gone on to do more things. And I think here, so one of the first take-home messages is like, I got a lot of interventional cardiologists to study HIV, so that should be remarkable in and of itself. But I think what's wonderful here is that watching my mentees continue to work with each other. And so this is Ruchi Parikh and of course, Eric Sazemski. And then now that I'm getting older, having my mentees go on to mentor some of our other mentees at UCSF. And so this is Jay Tang, who worked with Eric and Ruchi, and of course, Katie Kentafia. So that's been a wonderful thing to see, to look at things like peripheral vascular disease in the setting of HIV infection. So the HIV population is aging, and this is from the Dutch cohort study. And if you flash forward to 2030 over here, you can see that it's predicted that 73% of individuals with HIV will be aged 50 and older. And with that, subspecialty clinics will be very important. So I established this clinic at San Francisco General back in 2005. It has changed now with time. So now it's something called the Golden Compass Clinic, looking at individuals aged 50 and older with HIV infection. And it's now very multidisciplinary. So it's looking at HIV neurology, not just HIV cardiology, but also dermatology, geriatrics. It's really served as a prototype for other HIV specialized clinics across the world. So that's been fantastic. In addition, I think as a type of antiretroviral therapy for HIV have changed over time, so have the cardiovascular complications. And so currently, now that we're using integrase inhibitors, this has shifted the types of cardiovascular disease that we see, things more like heart failure, atherosclerosis, and arrhythmias. So I'd now like to turn a little bit to description of the underlying mechanisms of this process. And so, of course, traditional risk factors are very common. They play a key role in HIV infection. And this study shows this incredible risk associated with cigarette smoking, that it's now suggested that some HIV patients lose more years to smoking than to HIV infection itself. And of course, antiretroviral therapy is associated with cardiovascular risk. And so there's a long amount of literature on this. To just like breeze through it, older studies show that protease inhibitors are likely associated with increased risk, partly due to dyslipidemia. This may be a little bit lessened in the setting of newer protease inhibitors like atazanavir. And abacavir, current use, is associated with increased cardiovascular risk. And so they say that individuals who are at high risk, you should probably switch off this agent. And of course, the newer HIV medication, which is integrase inhibitors and TAP, are associated with weight gain. And there's a lot of controversy whether or not this is associated with cardiovascular disease. So I think looking forward, there's always newer medications, there's going to be newer side effects, and we still don't understand, is there any cardiovascular benefit associated with starting HIV medication earlier? And so I think one of the great advances in the field was everyone was looking at the HIV meds, they were looking at traditional risk factors, but a lot of the work that Jen did while she was working with our group was the first to show that actually advanced immunodeficiency in the setting of HIV was strongly associated with cardiovascular risk. And this has been shown now with our group and others. It's been predictive of cardiovascular events and also subclinical cardiovascular disease. And this is a real shift in the thinking. And in fact, I think our group has really defined that key link between advanced immunodeficiency and cardiovascular disease, that increased risk persists in the setting of treated and suppressed HIV infection. And in turn, chronic inflammation immune activation remains elevated in the setting of well-treated HIV patients and is predictive of CVD. What's interesting, even though I'm a cardiologist, these set of findings have now led to a focus on inflammation as an effort to cure HIV infection. So I want to focus on some recent studies that have broadened our understanding of this disease process. First, using imaging to look at pathogenesis and impact of interventions. So FDG is a analog of glucose. It gets taken up by metabolically active cells. You can see here an individual with low uptake and an individual with high uptake on the bottom. And so working with Amit Tawakol at MGH, we use this to image inflammation in both the hematopoietic system and the arterial system to look at the association of HIV-associated factors. And so here you can see this FDG PET CT, an uninfected individual on the top. You can see the lymph nodes are very quiescent and they just light up on this HIV infected individual on the bottom. And there's a nice association between higher lymph node activity and worsened HIV disease control, as shown here on this slide. We also partnered with our HIV scientists to look at these highly HIV persistent assays that can look at less than one copy per tube. And doing this, we found that inflammation in these lymphoid tissues was consistently higher in HIV, strongly related to HIV disease parameters. And that was really one of the first studies that showed, that led to a focus on imaging to look at where the HIV reservoir was. And following up on that, we partnered with our scientists at UCSF to develop HIV-specific tracers. And this is VRC01, that is zirconium radiolabeled tracer to the HIV envelope protein, taking this from preclinical, translational, and then human studies, publishing first in human imaging a couple of years ago. This was also coupled with some unique tissue collection programs that have been developed at UCSF doing gut biopsies. This team has now done over 1,700 gut biopsies to date in persons with HIV. We also have a similar program for lymph node tissue as well as bone marrow, so LP. And so kind of putting these two together, we are using this HIV-specific tracer in preclinical animal and first in human studies. You can see here in an control, and that just lights up on the patient on the right. And then marrying this with kind of tissue indices of HIV disease control. And so on the bottom here, so looking at lymph nodes, you can see looking at viral persistence strongly relates to the lymph node activity using this tracer. So we hopefully have more on this in the future, and the imaging is done at UC Davis. And now I want to turn a little bit to sudden cardiac death. And so this is something that we studied like over a decade ago, looking at clinic patients. And so you can see here, so in, not surprising, more patients with HIV died of AIDS in this time interval in blue. I think what was surprising was that in sudden cardiac death, we found that the rates in HIV were more than 4 times higher than the general population. This left us, with a lot of questions. Why is that the case? And so we followed up the study working with Zian Seng, and he's established this amazing sudden cardiac death cohort in San Francisco. And this is a very comprehensive review of all deaths with a medical examiner, so getting autopsy, toxicology, medical record review. And I think here in the time interval of the study, it's remarkable that we identified 109 persons with HIV and 108 underwent autopsy. So that's really incredible. So, what did we find here? And so I hate this diagram, it's really complicated. So anyways, there was a lot of unrecognized drug use, right? And so that's bad. That's not something that a defibrillator will fix. And if you look at the sudden arrhythmic deaths here, it was a lot from atherosclerosis and cardiomyopathy. If you look at the rates of presumed sudden cardiac death and sudden arrhythmic death, they were all higher in HIV, and it was driven by findings in white men. I think what was most remarkable about the studies, we had access to the heart tissue. And so this is the trichrome staining of the hearts, and the blue is fibrosis. And you can see here, long story short, there was more fibrosis in the hearts of HIV-infected individuals. It was driven by interstitial fibrosis and not replacement fibrosis, is what you get in patients who have atherosclerosis. It was higher in patients who had arrhythmic deaths as well. And I think, what didn't make the paper, but I thought was probably the most interesting, was that we did have nanostring profiling on these individuals. You can see here that markers of macrophage activation were associated with this increased myocardial fibrosis, then suggesting that chronic immune activation drives that fibrosis that we're seeing in the hearts. So this is the nanostring is from the heart tissue. It's from the heart tissue. Yep. Oh yeah, so please stop and ask any questions. So we're also looking at, heart failure is higher in the setting of HIV infection. It's higher, so this is both HFrEF and HFpEF, and it's associated with poorly controlled HIV disease, as well as some studies showing an association with protease inhibitor therapy and heart failure. So working with 2 of our prior fellows, and this is Teresa Wang and Nalini. We looked at biomarkers of microbial translocation to show that gut markers of TMAO were elevated in the setting of HIV, and they were associated with fibrosis by cardiac MRI. And this could be because of HIV disease pathogenesis and the direct impact on the gut. So this is one of the first studies, linking this gut biomarker and myocardial fibrosis. We partnered with kind of other unique cohorts at UCSD. There's an interesting cohort called the Last Gift, and these are patients who are living with HIV who pre-donated their bodies to science, and they get autopsy within 6 hours of death. And so we have some unique specimens from them. And then working at UCSF, we are banking heart tissue right as it comes out of the OR and have banked like around specimens on 50 individuals. So we have some preliminary data on these specimens, and this is a single cell RNA-seq, and you can see these UMAP projections in the HIV-infected individual, perhaps a suggestion of higher association with like lymphocytes and NK cells. And so working with Neil Chi, we have plans to look at disease in a dish model to look at the impact of immune activation and different antiretroviral medication on individuals with HIV infection. So one issue that's plagued the field is traditional risk calculators do a terrible job of predicting risk in HIV infection. I think that's not surprising to all of us. They focus on known pathways, and so they probably don't yield the best risk prediction. And so I know here, Dr. Gerson and others are doing lots of proteomic work, and this is unique because they can change and reflect the environment. They can reflect underlying biology. And one of my colleagues at UCSF has done this to look at risk prediction in the setting of stable coronary heart disease. So working with Matt Freiberg, Peter Gantz, and Mark Segal, we are using precision medicine to develop a risk prediction model in the setting of HIV infection. And we've studied now individuals in the VA cohort study. And so it's around 1,500 individuals with HIV infection. We have, as a first pass, identified novel proteins associated with mortality. And so these diagrams are really hard to read, but this is the Bonferroni line of significance, which is dotted, proteins that are associated in red, and then protective in blue, as shown here. I think an easier way to look at this is to look at it in a table form. And so these are kind of the top 10 prognostic proteins for mortality for HIV. And you can look at their names, their biologic functions, and whether or not they're targetable. And so proteins shown in yellow are protective for mortality, and here in white are associated with mortality. We modeled these to see, how they compete with things like age and HIV indices, and they strongly retain significance. Also looked at comparison with coagulation and inflammatory markers. They strongly retain their significance. And then you can look at the time-dependent ROC curves for mortality. You can see that there's relatively good discrimination, at least in these early years, in both the training and testing set. So this is one of the first large-scale proteomic studies in the setting of HIV infection. We're now doing this in the setting of MI and also heart failure as well. So now I want to turn a little bit to the different therapeutic trials that we've done. What time is it? I cannot see. Am I like, is it? Okay, okay. I want to turn a little bit to the studies we've done in these different disease states. And so while we've talking about antiretroviral therapy, it controls HIV infection, but it doesn't cure it. So you have ongoing viral replication, you have side effects from antiretroviral medication, co-infection with other pathogens like CMV. We talked a little about how HIV preferentially infects the CD4 T cells of the gut, leading to microbial translocation, their immune abnormalities. And all these come together to cause chronic inflammation, endothelial activation, and comorbidities, including cardiovascular disease, but many others, things like kidney disease, premature aging, and neurocognitive disease. And so with that in mind, there have been lots of studies to try to identify markers. And so I think what's remarkable here is in all these different cohorts, so old patients with HIV, younger men, women, they've strongly shown that inflammatory markers, IL-6 and D-dimer especially, are very strongly predictive to cardiovascular events and all-cause mortality. It's remarkable given the variability of these biomarkers in these different populations. And so this study pooled data from 3 large studies to show that IL-6 and D-dimer in particular are strongly predictive of these serious non-AIDS events and mortality in treated HIV infection. And they predict that, well, if you can lower those biomarkers, you could have a very profound impact on clinical events. And so as clinicians, what interventions do we think should be used to reduce risk? So should we look at low-lying fruit, like statins per se? And so recently, these are the current cardiology guidelines for statin therapy. And this, HIV is shown as a risk enhancer over here. And so that is individuals who have a calculated 5 to 7.5 risk. Those individuals, you could consider starting statin, you could consider imaging. Okay. There's other studies that suggest that HIV should be considered a cardiovascular equivalent like diabetes. So if you look at the European guidelines, they suggest that statin should be started to achieve an LDL goal that could be like 70 or lower. And if you compare the contribution of HIV to other strong risk factors, this could be reasonable as well. So earlier this year, the REPRIEVE study was published, and this is now looking at over 7,000 HIV-infected individuals, most of them with pretty low risk, and treated with pitavastatin. The study was stopped early because there was a 35% reduction here shown in first MACE and a 21% reduction in first MACE or death. And so I think for everyone in the world, what do we think? Does this mean we should just treat all HIV-infected individuals with statins? Yes? No? Okay. So I'm not on guideline committees, but this is my answer. I'm going to say not everyone. It's probably going to increase use among those age 40 to 75, maybe higher among those at that risk of 5%. And how did I get there? So if you look at this thing called number needed to treat, we know that the lower the number, the better, and the higher, it's probably less beneficial. And so the number needed to treat for Jupiter, remember, was 25. So if we look at here, the number needed to treat for the overall REPRIEVE was like 110. Okay, but if you break it down by a calculated risk score, you can see that if you look at patients at a low risk score, the number need to treat was less beneficial. Patients with a higher risk score, it looks like the number need to treat was lower. So if you follow these existing guidelines, individuals with HIV with this calculated risk of 5% using our existing thresholds would be recommended for statin therapy.
So what was the mean age for those individuals compared to, say, Jupiter?
It was pretty similar. Yeah. But remember, Jupiter had that CRP cutoff. And yeah, it's interesting. They didn't have that same cutoff here. The inclusion criteria for REPRIEVE was highly complicated. So they actually included some individuals with diabetes, some individuals who had an ASCVD risk greater than 10%. So it's in the supplement that's like 100 pages. So it's complicated. Yeah. So does a low calculated risk in persons with HIV equal no benefit from statins? And I'm going to say no, because if you use existing guidelines, a lot of HIV-infected individuals who would not be merit statin therapy had evidence of significant plaque. And actually, if you look at this REPRIEVE study, more than 49% of those individuals had plaque. Even patients who had a very low calculated risk, 30% of them had plaque on CT angiography. So even as a cardiologist, we hate this kind of imaging in asymptomatic individuals. I wonder if this could be used to refine risk and optimize primary prevention, although I realize I could get killed for saying that. So of course, Kazi saw this study coming, and he did this great cost-effectiveness study to show that pitavastatin versus pravastatin would not be cost-effective at its current price point. And if we think HIV-infected individuals are at high risk, and so they should likely, a lot of them should be on statin at this point, I want to turn our attention now to this residual cholesterol risk, and then we'll look at the residual inflammatory risk. So we know that lower is better in the general population, not just for LDL cholesterol, but also for inflammation, as shown here in red. And it's crazy that 18 years ago, we thought statins would be the best for atherosclerosis, as good as it gets. And so, of course, now we have injectable lipid-lowering therapy, the PCSK9 inhibitors. So twice weekly injectables, or actually now several month injectables, inclisiran. And so Pyle Coley did a study looking at PCSK9 levels in the setting of HIV, showing that they're higher, especially if you're co-infected with hepatitis C, and that they seem to mirror inflammatory levels in the setting of HIV infection. I do have to wonder if there would be a benefit to having a lower LDL cholesterol and doing this earlier in HIV infection. And certainly, if we look at the PCSK9 literature, it shows that non-statin therapy on top of statin may have a beneficial effect on events, and starting PCSK9 therapy earlier rather than later may be associated with mortality. So at the late-breaking sessions at AHA last month, 2 years of pitavastatin therapy in HIV, it effectively reduced non-calcified plaque, but it was not really driven by inflammation. It was solely associated by the magnitude of LDL lowering. So will having a lower LDL in HIV and doing this earlier be beneficial in this population? So working with Amit Tawakal and Michael Liu at MGH, we are looking at the impact of PCSK9 inhibition in HIV to look at the impact on non-calcified plaque. And of course, there's many other lipid-lowering agents on the horizon. Bempedoic acid significantly lowers LDL cholesterol as well as CRP and reduced cardiovascular events in the general population. And we are studying this now in the setting of HIV infection. So now I want to turn a little to the residual inflammatory risk on the right-hand side. The statin studies in HIV show very little moving of the needle of inflammation. And this is including the study, the pitavastatin study, the reprieve. Really no change. We don't know statins are going to hit those inflammatory targets we think are important. Our group looked at using low-dose methotrexate in HIV, really to look at safety. We found there was a small impact on CD4 count, which is not a good thing. We found that there was a more significant impact on CD8 T cell count, which is a target for HIV cure. There is no impact on inflammation. And this is one of really the first and largest studies of immunomodulation in HIV infection. And of course, after our study was published in the general population, methotrexate didn't really touch inflammation or events also. What about if we go up further on the inflammatory pathway? We talked a little about statins that impact CRP. So canakinumab is affected by cholesterol crystals, turbulent flow, and hypoxia, and it's a monoclonal antibody to IL-1 beta. We know in the general population, it lowers inflammation and clinical events. It may have this unique impact on cancer as well. We did a small proof of concept study to look at the role of IL-1 beta inhibition in HIV. We found that luckily it didn't seem to impact HIV disease control. There was a significant reduction in CRP and IL-6, and also a significant reduction in arterial inflammation as shown here, as well as hematopoietic activity. We partnered with virologists at Emory. They showed that levels of IL-1 beta were strongly associated with levels of the HIV reservoir, and a subset of these individuals, after getting canakinumab, significantly reduced their HIV DNA levels. So we're still trying to figure out what that means. We know in the general population now that colchicine, both after an MI and in chronic cardiovascular disease, is beneficial, and it's the first anti-inflammatory agent approved to be used in myocardial infarction and atherosclerosis. It has been tested in a small study in HIV, really showing no impact at this time. And I was very intrigued by this meta-analysis by Paul Rickard that was published earlier this year in the general population to look at the impact of inflammation and also lowering cholesterol lower. And here he showed that it really was a persistent inflammation that was strongly associated with clinical events, suggesting that aggressive lipid lowering combined with aggressive anti-inflammatory therapies might become the standard of care for athero in the future. I think as cardiologists, what we learn about HIV can also help us to inform the larger population. So we know of athero in general that there's both innate immunity and adaptive immunity. From our studies in HIV, we think that canakinumab may have an impact on innate immunity, while low-dose methotrexate may impact more adaptive immunity. And this was, tools to study chronic inflammation in the setting of HIV. We also know for atherosclerosis in general, we look at the pathway on the left, and then atherosclerosis in HIV. Of course, many overlapping pathways. helping us to learn about the immune system and cardiology. And so HIV has been a fantastic model for chronic inflammation that can help inform treatment strategies for all patients with CVD. There has been an interesting turn and focus on chronic inflammation and HIV cure. And so here you have HIV disease, chronic immune activation leading to fibrosis and poor HIV control, and it's kind of a vicious cycle. And so you could do two things. If you think inflammation causes chronic HIV, then anti-inflammatory strategies could break this vicious cycle. And kind of the harder thing to do, if you think persistence causes inflammation, then curing HIV will get rid of this problem. Many different, this is a pathway looking at HIV infection, chronic immune activation, and different targetable pathways. Of course, many efforts are being done to target each of these components. We recently looked at the role of sirolimus in the setting, showing there was a reduction in HIV-associated reservoir and a complex interplay on inflammatory markers. We're also looking at now different anti-CMV therapies in this setting. And what about the role then of viral persistence and atherosclerosis? And this was done by Megan McLaughlin, who's a UCSF cardiology fellow, to show that these higher levels of viral persistence were strongly associated with subclinical atherosclerosis, then suggesting that therapies that impact the HIV reservoir might also have a beneficial impact on cardiovascular risk. So I think here I'm trying to present a model here of HIV reservoirs at the bottom of this tree, and then you can have macrophage activation in the trunk. We've tried to impact that with therapies. And then in our branches, we have inflammatory pathways, and then the leaves are end organisms. So this is a nice model. And I think we realized in reality, the picture is probably much more complicated than what we presented. Now I want to turn our focus to COVID-19 and some of the studies that we've done. So our group pivoted in the pandemic to apply our expertise in HIV, immunity, and immunotherapy to SARS-CoV-2. And I love this quote from Tony Fauci that everything we do from other pathogens spins off what we learned from HIV infection. We've done some trials looking at immunomodulation in the setting of acute COVID, and I'll touch upon those. And so this is actually us consenting a patient through the door, which was a new technique for me. So we've looked at colchicine, the setting of outpatient COVID. And so in the Col-Corona study, this is a painful study to do because it was a no-touch contact. So I think it was unique because we consented patients virtually and their colchicine got couriered to them. So we never met them in person. Long story short, no association with colchicine in the outpatient setting of SARS-CoV-2. If you looked at patients who actually got the diagnosis using PCR confirmed testing, there was a hint of an association as well. We also looked at canakinumab in the setting of acute COVID in hospitalized patients. Again, long story short, doesn't seem to be an impact on clinical events. If you looked at patients who only got canakinumab and didn't also get, tocilizumab and other immunomodulatory agents, there was a suggestion that canakinumab was beneficial. We then started studying a little bit more about long COVID. And so how did we even know that this existed? First reports on social media in 2020, advocacy groups, New York Times. Then Congress allocated over $1 billion to this, and that got, I think, a lot of people's attention. And there's a large NIH effort called the RECOVER study that UCSF is part of that started in 2021. So long COVID is very, very common. It's present in around 40% of individuals, defined as unexplained symptoms more than 3 months after acute infection. Interestingly, it's very similar to other long syndromes in the setting of other infections like Ebola and GI. And in a recent CDC report, the prevalence of this is around 7.5% in the US population. So it affects a lot of people potentially. We're very early at our understanding of mechanisms underlying this. We know the predictors, female sex, older age, diabetes are associated with this phenomenon. And certainly things like abnormal immune responses, clotting, and chronic inflammation could be associated with this. And other mechanisms that we just don't know about. So at UCSF, our group and others have established this link cohort, long-term impact of infection with novel coronavirus, because we didn't even know what was it called then. And it's amazing. It's really led by Michael Peluso, a junior investigator, over 800 patients, 50,000 specimens, 50 collaborations. I think providing very important insights into long COVID with respect to immunophenotyping, immunity, and impacts on the neurologic system as well. We also used our expertise in gut biopsy to look at samples in long COVID and compared this to pre-pandemic control samples, looking at immunohistochemical visualization and also staining. And so this is now looking at a gut biopsy to look at SARS-CoV-2 in a pre-COVID infected control. And then you can see here, there is presence of SARS-CoV-2 in a patient with long COVID that's detected in the gut now more than 158 days, and in this patient, more than 600 days after COVID infection. And the SARS-CoV-2 is really localized in CD868 positive gut cells in the gut, less so in CD3, so lymphocytes. So we're still trying to figure out what this means. We are going to look at now individuals who have COVID but do not have long COVID to be able to follow up on this. Now, in the field, chronic inflammation, similar to HIV, has been consistently identified as a contributor in long COVID, and this has now been shown in many different studies. Our group also pivoted to look at cardiovascular implications of COVID-19 using different imaging indices, CPET, and also tilt table testing, which I hate doing, so, but we have looked at that. And some of the early findings from our group showed that even after doing all this imaging, the echoes are pretty normal, the MRIs are normal, except for maybe more pericardial fusions in patients who have cardiopulmonary symptoms and long COVID. We then turned to CPET to try to identify more abnormalities, and we found that there was abnormal peak VO2 in the setting of long COVID, and other groups have found this as well. Looking at this data more carefully, we found that this decreased peak VO2 in the setting of long COVID was due to chronotropic incompetence. And we've also now studied this in the setting of HIV infection. It's interesting that HIV, with or without COVID, is strongly associated with chronotropic incompetence. And if you look at inflammatory markers, it looks at higher levels of IL-6 are associated with worsened exercise capacity and also worsened chronotropy in the setting of both HIV and long COVID as well. So I think here we are in dire need to construct a unified model on how we go from SARS-CoV-2 infection to long COVID. I hope you see some parallels and similarities to HIV infection, so viral persistence, immune activation, systemic inflammation. And what's great is that each of these mechanisms are targetable. We can do that with antiviral medication, monoclonal antibodies to look at inflammation and others, and also specific interventions to target microvascular disease. So our group at UCSF is looking at monoclonal antibodies in one of the first trials in the setting of long COVID. We just started this a couple months ago, and the individuals are getting very detailed assessments for both COVID symptoms, as well as biomarkers and some of this gut biopsies and tissue assessments as we've talked about. We're also very interested in looking at baricitinib. It's a JAK kinase inhibitor. It's an immunomodulatory treatment that's FDA approved for COVID-19. It's been shown to be beneficial in hospitalized patients. And now in the outpatient setting, we'll be doing a study looking at baricitinib in 500 individuals with long COVID. They're going to get very detailed cognitive assessments as well as cardiopulmonary exercise testing. So I hope we'll have some results from that in the future. In the last minutes, I want to turn to future studies that our group is doing. And so I've been super excited to learn more about biologic and gene therapeutic interventions. And we're building off this Living Therapeutic Initiatives, which is a $2 million initiative to produce and manufacture these types of interventions at UCSF. But with my colleagues, we're building the infrastructure to do these trials first in human studies, focusing on cancer, HIV, and hopefully cardiovascular disease in the future. It is a multidisciplinary collaboration with scientists, imagers, and also tissue banking. And so one of the, I think, first ways to study this is in the setting of HIV cure. Why do we need to do this? At the beginning of the talk, I mentioned around 38 million individuals living with HIV. There's only been a handful of individuals cured. You can do this by like blasting and eradicating the reservoir, or you can kind of control the reservoir and then induce this remission. And this can be controlled then off of HIV medication. So this has been looked at using a CAR T-cell therapy, and this is with my mentor at UCSF, Steve Deeks, 20 years ago, redirection of T-cells, modifying the T-cells, and then elimination and protection against HIV using a duo-CAR T-cell approach. So at UCSF, we have done the first in human study to look at the safety and the efficacy of this duo-CAR T-cell in HIV-infected individuals. So the study is like incredibly hard to do. And so what are the rules for monitoring at UCSF? The patients had to be in-house for 24 hours. They couldn't work or drive for 4 weeks. So basically, long story short, we couldn't do the study at UCSF. We had to shift it to UC Davis. And right now, this is a little bit outdated. There's now 3 persons who've been treated at this time. We're also very interested in using gene editing approaches to elicit cure. So if you look at 2014, special HIV-directed guides to eradicate DNA, excision of integrated DNA, HIV from human CD4 cells, looking at this in a humanized mouse model. And in 2020, this was looked at in non-human primates. And several years ago, the FDA cleared these first-in-human studies. So it's a very intensive protocol. Patients have to be hospitalized. They get blood drawn for 14 days. They stop their HIV medication, and then you have to follow them up for 15 years. So 3 people have been studied now, and this was presented last month at this European Gene Cell meeting, and there were no toxicities. And so this, I'm gonna say, and then it was recently got a fast track designation, this therapy. So this was a failure for us at UCSF. We tried for 2 years to get this started. We could not get the contracting process going. And then when we finally did, it was too late. So we were supposed to enroll 1 patient, and then the company went with a faster, someone else who could enroll patients for cheaper and faster. But we have learned a lot from this. So as a non-oncologist, starting on these gene and cell-based therapies, we know that all these protocols are developed in the context of fatal disease. And so you have intensive monitoring. And of course, for gene editing, there's unknown risk for decades. And so how do we adapt this in the context of things like cardiovascular disease that are non-fatal? And certainly this is coming down the pipeline for us in cardiology. So we have to think about how we do this and study this in the field of cardiovascular disease. And then finally, I want to turn now to collaborations that we've started using ongoing global studies. So the Search Sapphire study is a huge community-wide population study in Africa to test and treat for HIV infection. They've now turned their attention to comorbidities, and we're hopeful that the study and collaboration will help us foster and grow global cardiology at UCSF. And we have started new collaborations with our colleagues in Uganda. They have a strong research infrastructure in which they've done bronchoscopy, TB, and pulmonary testing in individuals at Makere Hospital. We will be now adding evaluations of cardiovascular testing on top of this, so we're excited to start this collaboration. We will be setting up CPET in their facility as well. And then what about new biomarkers? So we know that CHIP is a hot biomarker in the cardiovascular world in general. Pradeep Natarajan recently showed that this prevalence is higher in HIV infection. And so we just got a grant to look at CHIP and HIV and cardiovascular events and to dive a little bit more into the mechanism. Is this from chronic inflammation? Is it from viral persistence? And we'll be doing this in the context of several cohorts. I'm going to turn a little bit to some work with the fellows that we have ongoing. This is Megan McLaughlin, a current UCSF cardiology fellow, looking at statin use in HIV in our clinics. And you can see here that, interestingly, we're not doing a good job of screening individuals who are eligible for statins. We can see here that 87% of individuals were screened, 43% were eligible for statins, but more than half of those who were eligible for statins were actually not on them. And certainly in the context of that REPRIEVE study, it's an important reminder to all clinicians to think about statins in the setting of HIV. We have undertreated HIV-infected individuals. She's now doing a digital text messaging study to kind of educate caregivers and patients about cardiovascular health and the possibility of statin use. At San Francisco, and I realize this is a very California-centric issue, but we have a lot of methamphetamine-associated heart failure, and so we are establishing a cohort to do imaging and to follow these individuals longitudinally. This is kind of our first look at this. We found that there was a very high death rate, so I think in our 46 individuals, 6 of them died over short follow-up. We are doing echocardiography imaging, biobanking, as well as cardiac MRI. You know, you can, of course, imagine the things that would be associated with better mortality. So patients who are on a medication, who had more reversible EF. And then, of course, our group is looking at disparities of care for heart failure, which is kind of a new pivot. Matt Gerstenfeld showed that there's strong disparities with regards to who gets cardiac cath in the setting of heart failure and who gets a defibrillator therapy also as well. So less than 10% of our patients at San Francisco General who are eligible for primary prevention defibrillator therapy actually got it. And so we're looking at that there. And then Diane Gian, who's a current UCSF cardiology fellow, is looking at the association between socioeconomic status and heart failure readmission. And you can see that, you know, not surprisingly, these look at the geocoding that these low-income neighborhoods are associated with worsened heart failure readmission. And then Shannon Walker is a current UCSF fellow. She is looking at the environmental and genetic impacts of methamphetamine-associated heart failure and pulmonary hypertension. She is studying this in the context of MVP, as well as establishing a local, in the context of our local methamphetamine cohort. Colette DeJong is a current UCSF fellow. We're really proud she got the ACC Merck Research Fellowship Award, was very interested in kind of the polypill setting for heart failure. And so you can see here, she actually bought an over-encapsulation device and she put together these different pills to show you the size. And so if you look at atorvastatin here versus some of these polypills of the different elements of GDMT put together. So she will be starting a clinical trial of the polypill at San Francisco General starting actually this month. So really excited about that. And then finally, am I over time? Okay. So this is I think this is my last slide. So Felicia Chow, who's a neurologist at HIV at San Francisco General, studying lots of HIV, looking at imaging and the burden of high intracranial abnormalities in the setting of treated HIV. So I think in summary, I hope I've taught you a little bit about cardiovascular disease and HIV. The biology of this chronic inflammation is complicated. I've demonstrated 2 different trials, low-dose methotrexate and IL-1 beta. I hope I've convinced you that some of these questions that we'll study in HIV infection and long COVID can help us as cardiologists learn about disease in the general population. And in turn, understanding this impact of immunomodulation, HIV can have an impact on HIV cure. We can apply similar investigations to HIV to other viruses like COVID-19. And we've touched a little bit on cell and gene-based therapies in HIV infection. With respect to treatment, we've talked a lot about lipid-lowering therapies, touched a little bit about anti-inflammatory strategies as well. And there's a ton of gaps in this field. We don't know if HIV should be like a risk equivalent, like diabetes. Should we lower LDL earlier and lower? How do we target inflammation in HIV and perhaps the general population? How do we move this field forward? This is a nice scientific statement that was led by Matt Feinstein, one of my mentees at Northwestern. We have established a K-12 program at UCSF to train individuals studying comorbidities and HIV infection. And with that, I just really want to thank my research team and all my collaborators, and happy to take any questions. Thank you. Yes.
Given that CAR-T itself is associated with cytokines,
Yes.
Is there any concern that it might actually exacerbate HIV?
Yeah, of course. Yeah. So definitely that's a possibility. So we're, of course, in the context of the CAR T cell therapy, we are carefully monitoring safety, We're looking at all sorts of T cell activation, inflammatory markers. So far, the first 3 patients have done well. So it's always a concern, right? I think in the Verve trial that was presented last month, that patient that had the event the day after the infusion, you wonder if it was some kind of like inflammation, like Sears, you know, kind of event that precipitated that. That's a great question.
Your work on sudden death is interesting. The same as two questions. Showed a lot of fibrosis in particular myocardium.
Yes.
Did you also find an increase in LVH? Also,
Looking at left ventricular hypertrophy. Yeah, so we did adjust for LVH when we looked at fibrosis, and we did look at LVH and sudden death, and it did not seem to be associated in our study.
And you know, sudden death is a heterogeneous entity.
Yes.
And finding the fibrosis in the myocardium, the ventricular myocardium, is nice, and it may predispose to.
Yes.
But it also is possible that you could radiate
Yep.
in some of these people too. And the problem with the anatomy is that it doesn't tell you the function. And what about taking the population of these patients still alive and then you see arrhythmias?
That's a great question. So we have thought about that, and I think it's, yeah, I think that's a great idea. Because, you know, of course, the CAM and cytopatch studies have been done, looking at just like a very short duration, have not really shown significant, I would say, arrhythmias in the setting of HIV. But I think definitely that would be like the gold standard, right? Planting implantable loop recorders, looking at myocardial fibrosis, looking at arrhythmias over a longer period of time. So, yeah.
So that was a great talk. I have one science question.
Okay.
A broader kind of philosophy question. So the science question is one of the most striking gene by HIV interactions is APOL1.
Yep.
So individuals with APOL1 variants have an 80-fold increased risk of chronic kidney disease.
Yeah.
So have you, A, looked at individuals with African ancestry who have that variant? Because it's also associated with coronary disease
Yep.
as well.
Yep.
Have you looked at those individuals? And 2, there are now studies out there from Vertex. There's a drug that really look like it not good and they work. So have you thought about using that as a biomarker? And 2, have you thought about therapeutic?
Yeah, that's a great idea. There have been some genetic studies in the setting of HIV. I don't think they have honed in on APO B1 in particular, but I think that's a fantastic idea. I don't think it's been done. Yeah.
The second question is kind of a broader one. And what's the survival of individuals who are HIV positive?
Yeah.
How much does that differ from the broader community? You brought up Verve.
Yep.
I'm going to say it too loud because it's about 4 blocks away.
Okay.
It's been a friend of mine for 25 years.
Yeah.
But if these individuals have, you know, the same life expectancy and the drugs work.
Right. So you could ask,
why
that's a
would
great
we
question. I could ask you the same thing about Verve and lipid lowering, right?
Right. Yeah,
So, so just to
we
play
had this-
devil's advocate, yeah.
Alec and I
So
had the
it's
same-
kind of it's the same thing. I see. So with HIV, the disease is controlled, but it's not cured, right? So the individuals with HIV, even though their life expectancy is longer, they still have now all these comorbidities. We focus on cardiovascular disease, but they have like neurologic disease, kidney disease, liver disease, premature aging. And so it makes them better, but they're not back to normal. So, and then also, even though antiretroviral therapy is available, you're right, in many countries, a lot of patients, they either don't get them or they don't take them. They don't, it's just like heart failure, right? If everyone took GDMT, those 4 meds, it would all be cured. But a lot of people can't or don't take them. And it's the same with HIV medication. So interestingly, injectable HIV medication now, that's like every 3-month injectable, is probably gonna be the way of the future, just like injectable medication for lipid lowering. Because they don't want to take a tablet every day, they don't like pill burden. And these individuals are mostly a lot younger, I think, than, you know, a lot of our individuals with cardiovascular disease, so.
I'm not asking you to defend the
The whole
It's just
like
something that we-
CRISPR-Cas9
We're
field.
all talking about it a lot, I mean,
Yeah,
the whole community stuff.
There's also a heterogeneity because there's this whole topic of HIV.
Yes,
All of those outcomes, both in terms of openness to treatment.
yep.
And do we know whether that's environment or gene?
Well, certainly.
Yeah.
Yeah.
It's stigma, yeah, so, yes.
I have probably a naive question, but is circulating viral load enough of an assessment of the burden?
No,
Because your tissue, you showed that all the tissues. was
Yeah.
reservoirs. So do you think at some point there should be imaging for tissues for us to try to figure out what that burden?
yeah, so the HI field is rapidly doing that. So you're right, like just getting a viral load undetectable is not enough. That's like saying the LDL is less than 100, right? So it's using these specialized assays to detect the single copy of HIV. I think the problem in the HIV field, it's like finding a needle in a haystack. And so the best ways to do that, you know, how to do that are rapidly evolving. And so that is a challenge. But yes, I agree with you.
So just going back to the breed, do you think that there's something magical about the concept?
I don't think it's a magical pitavastatin. So you know, why did they choose pitavastatin? So right. And so I think the what was thrown out, there's less drug-drug interactions with HIV medication, but with modern HIV therapy, that's not an issue. You could argue that pitavastatin is a moderate intensity statin. And if we think this is driven by LDL lowering and perhaps pleiotropic effects, that a more high intensity statin like atorvastatin or rosuvastatin would actually have more bang for your buck. So.
Thank you. Are there any, I'm struggling to understand like differences between, you know, someone who has suppressed viral or well-controlled HIV versus a period where they had a significant inflammatory active HIV, and also in the context of COVID, you know, people who cleared COVID quickly,
Right.
Or had a long bout of severe acute COVID.
Yep.
And it, you know, from my understanding is that, you know, in COVID, there's not much tracking in terms of viral load and those symptoms in terms of
Right.
severity, chronic severity.
Right.
How does that compare to HIV?
Yeah. Oh, yeah, sorry. So the question was on kind of early diagnosis of treatment of HIV and kind of comparing and contrasting that to acute COVID, if that's what I understand. So it has been studied in HIV, as you can imagine. So there have been a lot of studies to look at, you know, starting therapy immediately versus waiting. And so by our practice today, you can like guess how those turned out. So of course, starting therapy early is better. Not having a prolonged period of chronic inflammation, immune activation, viral reservoir damage, and fibrosis is beneficial. They've looked at the impact on inflammatory markers, and that is beneficial. They have looked at cardiovascular events too. Looks like it didn't reach significance, so it's probably because the patients were very young, like they're in their 30s, right? They didn't have any cardiovascular events, but we know it's beneficial with respect to chronic inflammation, immune activation. I don't know of many studies that have looked at this in the setting of COVID, looking at acute treatment versus chronic treatment. So I don't know the answer to that.
Well,
Yeah.
I guess I just wonder if there's any, you know, I mean, I think it's fascinating and really unclear what, you know, finding a few spike mRNA.
Right. It may mean nothing. Yeah.
I would bet that it doesn't mean anything.
It's possible.
And that, you know, the hit of COVID has changed our, you know, has modulated our immune system to be more auto-inflammatory or something else.
Right.
It's not the SARS-CoV-2 per se.
Right.
How our immune system functions.
Right. I totally could be the case. Yep. We don't know. Yeah. Yes. Yeah.
So this is a much similar question, but in your long COVID work, what is the universal definition of long COVID? Is it based on clinical symptoms or are there biological?
Yeah, that's also a great question. So it's generally considered symptoms more than 3 months after having acute COVID. And I think one of the difficulties of studying it, it's so heterogeneous, right? Because some people have brain fog, others have cardiopulmonary, some people have, persistent neurologic issues. So I think the heterogeneous definitions and presentations have been a challenge. Yeah. Okay, great. Thank you.